So welcome to Tackling Weight Discussions in Family Practice, Changes in Assessment, Management, and Treatment Outcomes You Need to Know About. And I'm Michele Werstuck. I'm a dietitian with the Hamilton Family Health Team and the nutrition coordinator, and I'm here with my colleague, Rebekah.
Yeah, so I'm also a dietitian with the Family Health Team as well.
So we wanted to do this webinar for you to give you a brief highlight of some of the new results that are being published in the 2020 Canadian Adult Obesity Clinical Practice Guidelines and how that may impact on our practice here within the Hamilton Fit. We've been doing some great work for many years, but the last set of guidelines came out in 2006, I believe. So it's been time for a new set of guidelines because there's been such significant evidence coming through on changes that we're learning about weight management and the complexity of body size. So today we're going to talk about specifically some of the changes in assessment and management and treatment that you may want to consider in your care, some of the changes in the biology of weight and appetite control that we're learning about, as well as some of the HFIT resources we can offer our patients living with weight concerns. So many of us know that we live in a very weight-obsessed diet culture, and many of our patients that we see are not happy with their body sizes and shapes, and we'll hear lots of messages from our patients around foods, around changing food choices, restricting foods, I'm detoxing, I'm following keto. Many of these messages are not evidence-based. Some are, but many that we hear, the majority may not be evidence-based. And really our goal as healthcare providers is to promote health and do no harm. And so we really need to be well-informed ourselves of the most recent literature and evidence, and really need to work together to offer consistent messages based on the best evidence that we currently have. Dieting may seem harmless, but is actually not. There's significant literature showing that it really is impacting, particularly on children and youth, and kids as young as 5 are concerned about body image. We have an increased risk of eating disorders amongst our teens and adolescents who report restrictive dieting. And we have a 1.5 time increased risk of binge eating amongst people reporting restrictive dieting as well. In addition, when we actually look at some of the chemical or biological changes that happen with restriction, we do see increases in inflammation, worsening insulin resistance, impact on bone health and muscle mass, as well as the effect on some of the stress hormones, one example being cortisol, and specifically on mental health. And unfortunately, what happens with this sort of cycle of restriction, it can actually end up leading to weight gain, which is the exact issue the person wanted to avoid in the beginning. This is a cycle that many of you may have seen. It's called the no-win dieting cycle. It really starts with that restrictive pattern of eating that leads to deprivation. Eventually, the patient can't take it any longer, or they get something triggers them to eat. They want to eat to feel better. They do temporarily feel better, but then it's associated with those feelings of guilt and shame and depression and poor self-esteem, which leads to compensating mechanisms of further restriction. So again, this cycle continues, leading to more and more restriction in the pursuit of changing body size. Yet we know when we look at body size, it's a very complex set of factors that influence our body size, many of which are out of our control. Things like our behaviors, our food choices, or activity are within our control, but again, also influenced by many other factors. But things like the medications we need for some of the chronic diseases can influence our appetite and hunger and how our body metabolizes nutrients. Hypothyroidism is one example. We have changes in metabolism that, again, we're just starting to learn about the gut microbiome and how that may influence metabolism. We also have things like cultural expectations around foods and choices and body size. And all of these factors are very important in determining someone's body size. Genetically, there's actually a significant amount of genetic influence on body size as well. 40 to 70% is the most recent reference range quoted. And this is a screenshot of the complexity of the interplay of different systems on appetite and intake. And where we once thought was a very simplified calories in and calories out, we now are beginning to understand that it's much more complex than that, with many systems working together in concert. And we're starting to really understand how in different individuals, these systems may in fact work differently. When it comes to genes, this is a very interesting area that I'm interested in, because they're looking at some of the polymorphic genes that do influence things like hunger and calorie intake, as well as how we store fat, as well as downregulating satiety and the impact on metabolism and control of eating. And so their estimates is almost up to 50% of the population may have different polymorphic genes, and these are just a few that I've thrown in there, that may influence this whole process, again, leading to that underlying emphasizing how complex this neurohormonal biology of body size actually is. So here's a question for you. When you look at these two individuals, who do you think is healthier? In the past, many people would have chosen the person on the right because they were basing it on body size. But in fact, we do know that you can't tell how healthy someone is by looking at them. That body size and BMI, in fact, is not a really reliable predictor of either mortality or morbidity. We see large variations in BMI ranges based on different cultural groups, different age categories, seniors, for example. We see different curves for mortality. We see J curves, we see U curves. So there's a lot of confusing evidence around there around BMI, yet we rely on it often solely for the diagnosis of obesity. Here's one study that actually showed some very interesting results, where they took populations with different BMIs, and this was about, I think, close to 12,000 patients in this study, and they look at the hazard ratio based on mortality. And you can see when you have 0 healthy habits, and if you add 1 healthy habit versus 2, 3, and 4, and the healthy habits they looked at were adding more fruits and vegetables, daily walks, not smoking, and moderate alcohol. So you can see, especially in the group where the BMI was greater than 30, quite a significant drop, even with the addition of 1 healthy habit to their usual routine. And again, the progressive benefit of adding other healthy habits, reducing the risk of mortality. And again, this just further identifies the need that we can't rely solely on BMI as a sole diagnosis of obesity. The other aspect to think about is we really, in the past 10 years, have really expanded our definition of health. And health is really much more than just physical health. It really is that state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And so this is really informing how we start to look at the care we offer our patients. So Rebekah, I'll turn it over to you.
So Michelle's done a nice overview of the background influences on obesity and body size. And so this gives us a nice background to talk about what's new with the 2020 guidelines. So the main thing is that there's been a change in definition. So the 2006 guidelines defined obesity based on BMI. So BMI greater or equal to 30. The new guidelines is moving away from the BMI being the sole definition, looking at adiposity as it relates to health impacts. So the new definition with the guidelines is obesity is a chronic complex disease in which abnormal or excess body fat impairs health, increases the risk of long-term medical complication, and reduces lifespan. So you have to have those factors in order to be considered as an individual with obesity. They also are moving away from an overly simplistic view of calories in and calories out. And then looking at the impact of weight bias and weight stigma. So we know that weight bias and weight stigma are experienced by individuals with obesity, and this results in increased complications, mortality, independent of weight or BMI. And like Michele was saying, we do know that BMI is not an accurate tool for identifying obesity-related complications, so moving away from using that. So when we're looking at principles in primary care, there's a few things you want to focus on. So healthy eating is important for all Canadians, regardless of body size, weight, or health status. Again, BMI is not an accurate tool for measuring health, and addressing weight in a patient-centered way can reduce stigma. And so moving on, next slide here. So we are leading the way with this. So as a nutrition program, we have been trying to promote healthy behaviors for everyone, regardless of body size, for many years, and both our individual counseling and our group programs. So we try and provide patient-centered care, focus on behavior changes that impact health outcomes versus just focusing on weight loss alone, as well as respecting size diversity and reducing weight stigma, focusing on approaches that improve nutritional intake, quality of life, manage chronic diseases, and support a healthy relationship with food. We try and do this based on evidence-based practices tailored for the individual for the best long-term adherence. And one example of this is through our Healthy You lifestyle group. So this is now a 6-week online group that focuses on self-care, building a healthy relationship with food, and helping participants learn how to eat well, become active, and feel good about themselves. So we've had offered about 100 sessions with the family health team. Okay, next slide. So the other group that we offer, just to highlight, is our mindful eating program. And this group helps participants understand triggers to problematic eating and relearn new healthier associations. And so we do know that when we're looking at weight in obesity management and primary care, there's no one size fits all. So patients may benefit from multiple medical nutrition therapy strategies, including Mediterranean, DASH, vegetarian, low glycemic index, portfolio, so forth. So this list sounds pretty daunting, but our job is to simplify and come up with a realistic plan for each patient and their unique situation. So next slide here. So as we were mentioning, the new guidelines also address the need to be aware of weight bias and weight stigma. And at the Family Health Team, we have been working on this for a while. And so it begins in the waiting room, looking at the chairs that we're using, as well as the messaging that we're providing. We've been working with our teams to reduce weight stigma, have more sensitive conversations around weight, and then also trying to create a safe and respectful environment. So looking at the seats and chairs that we're using, is it comfortable for an individual of a larger body size? Exam table height, gowns, blood pressure cuffs, are the scales in a private location? And then assessing for our own weight bias and being sensitive when we approach conversations around weight. Okay, so I'll pass it back to you, Michele.
Okay, and we do have tools to help with the conversations around weight because it is such a sensitive issue, and that's something we're happy to share with you. So we wanted to apply this to a couple of cases in family practice to get us thinking about how it may change what we offer. And we have one case named Rianne. She's a 38-year-old female with a BMI of 30, no chronic health conditions. Her weight has remained the same throughout her adult life. As a child, she was always considered to be in a larger body size. She's pretty active, walking her dog every day for 45 minutes with regular healthy meals, and really been trying to move away from processed foods and incorporating more fruits and vegetables on a daily basis. And she's coming in to see you for seasonal allergies. So there's case one. Then there's case two. This is Jared. He's a 45-year-old city bus driver. He has type 2 diabetes, chronic knee pain, and sleep apnea. He's on medications, metformin, BID. His A1C is above target and his BMI is 40. He reports limited activity and struggling with some of his food choices, usually only eating one large meal a day. He lives with his sister and he has limited experience preparing meals. He mentions he's been struggling with depression for the past 3 years, and he's heard that what he eats can improve mood, and he wants help with healthier eating and losing weight. So here's one of the first things we want you to think about is with the new guidelines, we really want people to expand their assessment. We want them to move beyond just using BMI, and we want them to ask this question: is this a healthy individual living in a larger body? Which in that case, you would encourage healthy eatings and maintaining healthy habits. You wouldn't be focusing on weight loss. Versus, is this a person dealing with weight that is reporting is impairing their health? In that person, you would consider weight loss as part of medical management. And this is where we'd encourage you to use the 5 A's, which many of you have heard about for lots of chronic diseases: the ask, assess, advise, agree, and assist. But there's another new concept we wanted to mention to you called the 4 M's. And this is where we want you to consider this person when you're looking at this person and having a conversation about weight. Is their weight affecting their mechanical health, their metabolic health, their mental health, or their monetary health? And that's a really good question to ask your patient, because they'll have the time to sit back and reflect as well, really how much their weight is impacting. And I've had several patients actually, when we get into that discussion, really realize that their weight is not, in fact, affecting those parameters, and they feel quite well and quite healthy. And so it was quite an eye-opening moment for them. So it's a very valuable assessment question to be asking your patients. And of course, we want to make sure we inform patient of the variety of treatment options, because unlike 14 years ago, we have many more treatment options to offer. So with the 5 A's, one of the things that's really important is dietitians, we don't just throw a diet at someone. We really do try to explore the root causes of the change in weight this person's reporting. And we were trying to listen to the story to find out, what has happened, what is important to them, what are some of the aspects that could be influencing their appetite, their hunger, their food intake, their physical activity, or their metabolism. And this chart is a nice one because it actually does show sort of those 3 categories and some of the sub-factors that you may consider when you're having the conversations with your patients. But most importantly, before we even get into that assessment piece, is the asking piece, that piece to ask permission to talk about weight concerns. And that's an important part because you need your patient to be ready and wanting to talk about that. And they may not be at a point where they want to talk about their weight, nor may it be appropriate. So we will have to be mindful of that. This is a great tool from Obesity Canada and the clinical practice guidelines. And it does nicely highlight the 5 A's and this patient journey in obesity management. Again, starting with asking permission. Is it all right if we discuss your weight? Then getting into the story. What is the patient's story? What has happened in their life? How did it lead up to this point? What are their struggles? What are their goals? What do they want to achieve? Do they want to be able to run in the park with their grandchild? If so, it's important to know what's important to them so that when you're advising on management, you have that in mind and you can help tailor the choices to what will give them the achievement of their real value-based goal. So when you do advise on management, medical nutrition therapy and exercise are the cornerstones, or what we call the core therapies for weight management. But in addition, we have adjunct therapies, psychological therapy. As dietitians, we get into what we call nutrition CBT, particularly around some of the problematic eating. There's medication options, and I encourage you to join us in the next couple of weeks. I'll be joining Lucy Feng, one of our pharmacists, to talk a bit more about the meds that are available now, as well as bariatric surgery. So we have a variety of tools now. The next step is agreeing on what particular tool is going to work best for your patient, and starting with where they are at with very small, specific, realistic, what we call SMART goals that focus on small behavioral changes and tend to lead to more success in the long run. And then, of course, we talk quite a bit about assisting with barriers, because there's many barriers get in the way of behavioral change, and having that problem-solving conversation is very important to help your patient achieve success. So Rianne's case. So Rianne, when we think back to Rianne's case, she is a healthy person with healthy habits, living in a larger body, and really in a larger body for most of her life. There's no evidence of chronic disease or her weight affecting her quality of life, and she doesn't bring up any concern about weight. So in your assessment, in the 4 M's, like even in your own mindset, even without asking her, there's no identified impact of her weight on her health. You could still bring that up. But the question is, when you're thinking of the 5A approach, is do you bring up weight? If she's there for our allergy discussion, is that the appropriate time to bring up weight? We've heard from many patients, and we've seen in the literature that around weight bias, where many situations where healthcare providers have started to talk about weight when the patient's in the office for a non-weight issue, like a cold or an allergy, for example. So we have to be very mindful of that. The key message for all of us really is we want to promote nutrition for everyone, all body size, shapes, because nutrition is important for everyone. So that idea of focusing on health, regardless of body size or health status, and reinforcing the healthy habits that she already has, and body size acceptance, that whole discussion around body image is very important. And that's a role I think we all have to help support our patients to enhance that self-esteem and body size acceptance. As Rebekah mentioned, we have some great group programming here within our Hamilton Fit, Healthy You, which is our 6-week group. We also will have cooking classes starting up again when we get back to in-person groups. So we do have a lot of supports we can offer Rianne in terms of maintaining healthy habits and staying well. It's important, though, there is a little caveat to be mindful that there has been quite a bit of literature reporting nutritional deficiencies in individuals living in larger bodies. Iron, B12, vitamin D, magnesium, all very common deficiencies. And this may be related to many other factors. Medications, for example, we know water pills affect magnesium and potassium, but it also may be from history of restrictive dieting, because even though these people are in larger bodies and may be healthy, they may have been told to lose weight. And so therefore sometimes have gone on perhaps fad diets where the nutritional quality is not there. And so we still want to be mindful that these folks may be experiencing some nutritional deficiencies. And when the next set of blood work comes up, it might be something worth considering. And then there's our conversation. This is an area where I think we have such an impact as healthcare providers on how we say and provide information to our patients. And we're all guilty of, in the past, commenting on body size comments. Wow, you look terrific. Have you lost weight? But we really want to move towards more positive messaging that shifts away from body size and focuses on health and healthy habits. That idea of, wow, you've made so many positive changes. Your blood work's amazing, right? So we want to shift away from some of those body size comments, because we hear them from our patients as well. And sometimes they're quite harsh on themselves as well. And they report things like, I went in and the doctor said if I lost weight, everything would improve. So we need to be mindful of those conversations. And we hope to have another webinar focusing on reducing weight stigma and bias and other strategies we can use in our care in the future too. So stay tuned for that. All right, Rebekah, over to you.
Okay, so we're going to move and talk about Jared's case, which is a different approach. So just to summarize again, Jared is a 45-year-old city bus driver. He has type 2 diabetes and chronic knee pain and sleep apnea. He has limited activity, is eating out at least one meal a day, lives with his sister, and has limited experience planning meals. He has struggled with depression for the past 3 years and wants help with healthier eating and losing weight. So this is a bit different than Rianne's case. So when we look at the 5 A's, for ask, assess, agree, advise, and he is actually wanting to talk about his weight, wanting advice and assistance, and learning about treatment options. We can also see the impact of weight on different health aspects. So again, the 4 M's that we look at. So we see the impact of metabolic health. So this is diabetes. Mental health with the depression, and then mechanical health, which would be the sleep apnea and knee pain. So how do we approach these conversations? One of the key things that we want to do is validate the patient experience. And this is a really nice example of how to do that. So it is difficult to live in a larger body, especially in a society that values thinness. What we know, however, is that healthy bodies come in all shapes and sizes, and you can enjoy better health through good nutrition and regular activity, independent of any change on the scale. And so that part highlighted in green below is very important. We'll go into this a little bit more detail. So one of the key messages for providers is that we want to change our focus to health outcomes versus weight alone. And part of this is because we do know that food is medicine. So diet choices alone, apart from weight, can lower the risk of developing type 2 diabetes, heart disease, stroke, dementia, and certain types of cancer. So let's go into this a little bit more detail. And again, this is apart from weight loss. So lifestyle interventions can lower A1C by 1 to 2%, which is similar to 2 medications, reduce risk of diabetes by up to 70%, lower blood pressure by 11 points, reduce heart attacks and stroke by 28 to 30%. This is similar to statin therapy. Reduce risk of depression by 32% and Alzheimer's by 53%, and may possibly reduce the need for medications, which we know many patients are quite keen on that. And so part of our 5 A's is we do want to be advising patients on all treatment options. And so we have the 3 listed here, which we'll go through in a bit more detail. So when we look at lifestyle therapy, there's about 5 to 10% weight loss. And I think it's important that we are talking to patients about weight loss expectations, because many patients do have unrealistic expectations when it comes to changes in weight. So we want to make sure that they are aware of the actual observable weight loss seen through these different interventions. So again, lifestyle therapy, 5 to 10% weight loss. Pros would be they're developing healthier eating and activity habits, identifying and managing triggers to emotional binge eating. They're learning to reduce distress and preoccupation with weight. The cons are that it does require multiple sessions with a dietitian counselor. Weight regain can be seen in 6 to 12 months if old habits return. So this is where we really want to be encouraging healthy eating patterns that people can maintain long term. So we don't really want to be encouraging very restrictive diets that are difficult for patients to maintain and result in the yo-yo dieting effect. The next option here are medications, which results in 5 to 10% weight loss. This is less invasive compared to bariatric surgery. Medications, there's medications to suppress appetite, manage cravings, binge eating. So there's just a few listed here, Ozempic, Saxenda, things like that. There are limited options. There's side effects as well, mainly gastrointestinal. Significant cost, as a lot of these are not covered, and they do have to be used lifelong to maintain weight loss. And again, like Michele was saying, Lucy will be talking about the medications a bit more on the next presentation, so stay tuned for that. Bariatric surgery, so about 20 to 30% of total body weight loss, and this is for the Roux-en-Y gastric bypass, which is the most common surgery in Canada. There is evidence of improved blood sugar, blood pressure levels, quality of life, and self-esteem. Now, one thing just to be aware of that a lot of individuals don't realize is that they do have to take supplements lifelong, and they are not covered, so it can be quite pricey. And this is to prevent nutritional deficiencies, which can happen post-surgery. Weight regain does happen, and we do still have to monitor for blood sugar, blood pressure, and so forth, particularly if they did have diabetes prior to surgery. We need to make sure we're addressing the underlying issues. So for emotional eating, binge eating prior to surgery to improve success. And a really important thing that we need to also assess for is that there are increased rates of self-harm and suicide post-surgery. It shows here inside, it's kind of tiny. So 1.7 to 3.2 times higher post-surgery. So this is something we need to be monitoring in those individuals who've had bariatric surgery. Okay, so next slide here. So this may seem a little daunting when we talk about the bariatric surgery. So we do have a toolkit available with the family health team. And the goal is to provide ongoing follow-up and pre-surgical support to help patients achieve health goals. So we do really want to be seeing them and assessing before surgery. And we just want to be, in post-surgery particularly, trying to reduce these complications listed here, which I had mentioned on the previous slide. And so the dietitians are creating bariatric registries, and we have about 66 out of 90 offices using this toolkit, and we've identified over 800 post-surgical bariatric patients. So quite a large achievement here, which is wonderful.
All right. Yeah. Okay, thanks, Rebekah. So now we want to get to a couple of questions that we often get, because when we're talking about weight, there is always this concern about, is there risk of harm or benefit? And that's a very important question to be asking. And so, I've had one of my nurses was asking me, with the new guidelines, does this mean we shouldn't be talking about or measuring weight? And that's a good question to be having, because we want to be aware of any potential weight bias or stigma that we have around weight. But there are certain populations within primary care that we really need to be aware that signs of rapid gains in weight can be a red flag for other issues. And so, for example, adolescents, young adulthood, pregnancy and infancy. We know pre-pregnancy BMIs that are above 30 are linked with poor OB outcomes, more preeclampsia, C-sections, gestational example. And nutrition counseling can help reduce the rate of prenatal weight gain. So there's some very good evidence there. So that's a population where we could be preventing future weight gain, because we know it's much easier to focus on the prevention of weight gain than it is on weight loss. Well baby visits, another opportunity to be educating parents about healthy eating and expectations around food choices and food portioning and food decision making in general. Medications as well. There's many of our patients are on medications that may be influencing appetite. So as we learn more and more about how these different hunger hormones like leptin and ghrelin and insulin are affected, we are beginning to have a greater appreciation of the biochemistry of appetite control. And many meds, like some of our SSRIs and antipsychotics, our diabetes meds, can affect appetite and promote weight gain. As dietitians, we have a little bit of a cheat sheet that we use around which meds may be more weight neutral. We will be working with our pharmacy colleagues to perhaps create a more formalized document that may be another tool that we'd be happy to share with you. So let's summarize it and leave some time for questions at the end, which we hope you can enter into the chat box, and Rebekah is going to read them off for us. But really, where do we go from here? We've been doing some great work when it comes to offering service and support for our patients. But as we think about moving forward, we really want to encourage everyone to be thinking of a much broader assessment of weight, because not everyone that's at a higher weight is actually living with obesity. With the new definition of obesity, it's really that excess body fat that is affecting health and quality of life. So we're expanding the diagnosis of diabetes. And we want you also to be thinking about, when you're having discussions with your patients, being very sensitive to, is this a weight discussion the patient would like to have? Asking permission is a very important key thing to remember. And when we're, trying to assess, is this person living with obesity or is this a person in a larger body? The 4 M's, I think, is a very straightforward approach that many of us as healthcare providers find very easy to incorporate in the conversation with our patients. And patients, as I mentioned, really seem to like that discussion around the impacts on their health. We want to really advise against restrictive diets, which we know can be harmful and can lead to complications such as eating disorders and really ongoing feelings of guilt and shame. We want to be offering our patients healthy eating patterns that meet their nutritional needs so they're not deficient and yet they're enjoying food, right? There is no good and bad foods. We want to work with them to see what is important for their culture, for their nutritional needs. And really that's, we have so much to offer in that category, as Rebekah mentioned, many different healthy styles of eating, many different food-related patterns that have some good literature showing benefit on everything from blood pressure to A1C to inflammation. So if weight loss is recommended, we want to make sure we have well-informed patients. We want to advise them of all the treatment options, including the weight loss expectations, because I think, as Rebekah mentioned, that's a key part where our patients are extremely disappointed. They're always expecting a greater weight loss. And I think we need to be right up front with them to say, here's what we can expect to see. Here's what the literature shows us on average, and which of the options would work best for you, right? So it's really about giving them that choice. And then, of course, we want to continue our work around reducing weight stigma and offering patient-centered care, being considerate in the language we use with our patients and our teams, and offering patient-friendly environments where our patients feel welcome and able to share, their deepest thoughts and concerns with us. So we've created somewhat of a care pathway, trying to marry all these concepts into one page, and everything in the orange box that you see here are some of the key core concepts that we're hoping you walk away with today. And then the green, yellow, and red are the treatment outcomes or options we can offer. The green is also the group options we have to support. And the other important piece is that piece around working together as a team. We have a wonderful group of a variety of experts, and we really want to come together to offer what is best practice for our patients. And so the healthy eating piece, we're furthering our weight stigma, reducing strategies, creating those supportive clinical environments. We're going to try to plan another webinar in that in a few weeks, in probably end of July, so stay tuned for that. The Obesity Canada guidelines has a lot of these great tools for you. So if you're looking for the 5 A's framework for obesity management, I encourage you to go to www.obesitycanada.com/guidelines. Lots of great resources in there for you. But this is something that we hope may give people some framework around what we can each offer to support our patients. So on that note, we'll say stay tuned for our next couple webinars. Next one is July 14th on what medications can I offer my patient to control appetite and assist with the weight management. We're going to have another webinar on the mental health impacts of obesity and additional strategies we can utilize to reduce weight bias and stigma. And if you have any questions or need tools, feel free to reach out to me. I'm happy to connect you with our QI team to get bariatric tools installed or whatever you need. So thank you for your time. We tried to keep this short and sweet because we know you're all very busy clinicians and have a whole afternoon of patient care to deliver. So we wanted to open this up a little bit now for a few questions. Rebekah, do you have any questions in the chat box there?
We don't have any in the chat. So if anyone would like to type something, I can just read it out and then we can have a discussion. So any burning question, now is the time to ask.
We do have to say we're getting a lot of patient referrals. COVID has impacted on many things in our lives, and many of our patients are struggling with stress eating, they call it, or changes in their eating patterns and seeing changes in weight, often related to multiple factors. And so those are a lot of the patients that we're seeing, quite an increase in our referral base there. Mm-hmm. But in terms of management, Rebekah, any cases you've had over the past week that may offer a practice pearl for the listeners?
Yeah, so I think one of the things that like you were saying, we really want to encourage patients coming in to see us before bariatric surgery. And so I had one individual who was referred to me, and they actually, it ended up being they had binge eating disorder. So a lot of the criteria for that. So we kind of followed up with the doctor, and they were open to attending one of our groups through the family health team, which we have the binge eating disorder group, prior to looking into other avenues. So that just highlights looking at, like Michele was saying, those 4 M's that can be impacting health and weight and quality of life. So this is one of the 4 M's. So it'd be like mental, metabolic. It could fit possibly in there. And so I think in the past I was guilty of maybe not assessing that completely, but now looking at this full guideline, it's kind of helped, like you said, Michele, build on my assessment so it's more complete. And so we're identifying better ways of supporting patients. And this patient I saw was so appreciative of it. Yeah, and it'd been something they've been struggling with for years. So
absolutely. So we do have those tools for those of you who have TELUS EMRs.
Yes.
We have the binge eating screener, which is a tool that it can be added to your custom form list. We also have the other tools we should mention from the Green Initiative. We have the Plant RX and the Park RX, and these are lifestyle prescriptions to basically help you start your conversation with patients around building those healthy habits, those healthy eating habits, and those healthy getting outside, in green space habits, which we know are so good for mental health. And so that's important to remember. We have those tools. If you need help loading them into your custom forms, we're happy to help with that. But we have a whole variety of tools we're very happy to share, and we really welcome your feedback. If there's certain tools you want, so for example, if you want that resource on more weight neutral medications that are commonly used, we're happy to work with the pharmacy team to formalize that. We have
we actually have a request here, Michele. So there's wondering if we could share the clinical care pathway algorithm. Is that possible? Absolutely. Yes. Absolutely. Okay.
that care pathway is, again, it's a work in progress, and we really value team-based care. So we would love to hear from our colleagues in terms of pharmacy, mental health, psychiatry, our physicians, our nurses, our physiotherapy, for example. That approach where we have all disciplines is the best style, I think. And our patients really, really appreciate being linked to so many wonderful resources. And And I do spend half my time talking to our patients about all the amazing resources we have, and they're shocked because none of them know that they have
Yeah, it's
all
very
of them.
true.
So,
Now there's another question. So just saying in the lifestyle component, is there a specific guidance for physical activity? And so it would be great to offer something to patients with limitations to at least starting engaging in a form of muscle movement. And they were saying, I don't like to call it exercise. I tend to say just moving your body more throughout the day.
yeah,
I tend to do the same thing.
so again, at the Obesity Canada guidelines, there's a great one-pager on, they call it medical nutrition therapy because we do tend to talk a lot about activity as well, but it walks through some of the tools you can use in that 5A framework. We also have physiotherapists within our Hamilton Fit, and we can maybe see about resources they could be sharing as well with us that may be helpful connecting patients with just getting that movement starting, especially that person living with mechanical issues, right? Significant knee pain or difficulty walking due to water retention in the feet, etc. How do we help those individuals, maintain lean muscle mass and get stronger and reap those benefits of being physically more mobile, right?
Yes, and I find in the past there were like chair exercise programs that were free that a lot of people who have mobility issues enjoyed them more. They are online, but again, that presents barriers for people who don't have computers. But like Michele was saying, oftentimes those individuals might have already had a connection with physio. And so I often will suggest, why don't you talk to your physio and come up with a plan for activities that you can do in the day that would help with the pain and mobility issues, but also support other health benefits as well. And then there's a comment here. These ideas could help chronic pain patients too. Yeah, yeah.
Other comment I wanted to share is around the food police. So as
Mm.
dietitians, we get a lot of comments. Patients will come in and they'll say, this wasn't as bad as I thought. They're always very surprised because they're like, I thought you were the food police. And so we need our teams to help champion that we are here to help our patients find that eating pattern or merge several. Like how many times do we take a bit of a DASH eating style, merge it with a bit of a vegetarian style, with a bit of a Medi, right? So to come up with what works for that patient. And they're always pleasantly surprised. It seems to be an ongoing theme that they're so surprised that we work with them and not give them this very restrictive style of eating, which for some reason they tend to think. So we really are counting on our colleagues to encourage patients to meet with the dietitian because we're not so bad, are we, Rebekah?
I hope not. Usually I'm told, oh, that was much better than I expected.
I got $1 for every time someone said that. I'd be wealthy.
Yes. So
is there any other questions? Any other last minute? We want to be mindful because people are on a short lunch hour and they need a few minutes.
I don't have anything else in the chat here.
Okay.
Yeah.
Let's end there and say thank you to everyone for taking the time to join us today. And if you have other ideas around sharing further best practices around weight and obesity management within our FIT and what we could be doing, we really would welcome your feedback and your collaboration. And we'd love to do a webinar with you. So feel free to reach out to us. I'm hoping this is an ongoing conversation that we can continue with to really come up with some services that really meet our patients' needs. Okay, everyone have a wonderful afternoon and thank you again.
Yes, take care.
Bye-bye.